Welcome to this video in which we'll be showing you an anterior segment case, and here you see the area on the cornea. If I show you, this is the broad anterior segment slit, this is the anterior part of the slit, this is the posterior part of the slit you're seeing over here. If you look carefully in the anterior chamber, you will see a whitish level over here. Then these are horizontal lines over here which are representing Descemet's membrane fold. There's sutures over here, and then there's ciliary congestion over here. Let me just refresh what Descemet's membrane folds will represent. If this is the cornea, the corneal edema, the cornea becomes, posterior surface becomes more flatter. So that's why the Descemet's membrane becomes more redundant and it makes folds like this. Because otherwise, normally the posterior surface of the cornea is curved as the anterior surface, so you do not have any folds in the Descemet's membrane. So this is the Descemet's membrane which gets folded because of thickening of the cornea. So let's go ahead with this. Let's see. So this is a patient. Go on to higher magnification. Now you can see these horizontal striate keratopathy over here. And in the pupil, now you can see there's some strands over here. Here you can see the strands in the pupil. This is the strand in the pupil. So the patient was actually aphakic. So the pupil is sort of mid-dilated or probably less than mid-dilated, but the pupillary area is more of jet black in appearance in this area. So this is something which you have to see in these cases. And now I'm moving the light from one side to the other, and you can clearly see the striate keratopathy. And this is the red reflex. So the red reflex actually represents that the vitreous cavity is clear and the retinal reflex is coming out nicely. And then again, I want to show you this level of cells in the anterior chamber representing a hypopyon in this anterior chamber. This was actually a patient after post-vitrectomy for endophthalmitis, and these were actually layer of cells which we could see in the anterior chamber, and they resolved by themselves with continuous steroid treatment, and there was not an actual true hypopyon in this patient. See, and let's go forward on this and move the slit on the side, and then you can see the same things. The patient is aphakic, so you do not see any reflection from the surface of any IOL. Is no IOL is present, so you do not see any reflection in that area. And then these vitreous strands are available, and then the conjunctival congestion and the mild degree of chemosis inferiorly is also seen in these patients. So the patient was actually a patient who developed late onset endophthalmitis, and he had a removal of intraocular lens using a 5.5 millimeter incision. He was aphakic later on. And then there's another interesting thing which you see in this patient is these are some peripheral posterior sort of keratic precipitates you see in the peripheral cornea in this patient as well. So if we go forward, we'll see more of these. When here you can see those, and this is the superior limbus through which we had gone through and removed the IOL, two sutures over here. So, and there's an air bubble over here which you need to demonstrate to the examiners. If you see an air bubble like this, so what you will say, you'll say there's an air bubble in the superior part of the anterior chamber. Is probably 5% of the volume of the anterior chamber. And then the other thing which you're seeing over here, this is an area of all subconjunctival hemorrhage which was present because of the incision we had given over this area. So these are areas of subconjunctival hemorrhage along with ciliary congestion which you're seeing in this patient. So those all these things are very relevant when you're examining the patient and describing it to your colleagues or to examiners in your examination. Then you need to go on a higher magnification and see